are some requirements and how you brief the patient about what you are going to do. Tell me when there is double vision, tell me when there is pain, not at the end of the test, before the test. Of course, some easy points and crucial points that sanitize your hand, gain consent from the patient before doing anything. It is about collecting marks, but not everybody is the same. If Sabrina and Selena do the same test and get 15 checkpoints, one of them may get 17, one may get 13. Why? Because there is another grading regarding your confidence and the fluency of the test, the smoothness of the test. So it is not only performing the test, it is as well how you are confident and smooth during performing, and this is gained by practice. Extraocular motility, you can do it on any family member or friend. For the theory, of course, we cannot discuss today all the topics, it will be overwhelming. And of course, I will not tell you the 3 topics that are in the exam. If you are waiting for this, this will not happen. Why? Because it is not about the exam. So my advice, study group. You study with 1 or 2 or 3 or 10 of your colleagues, and you do what we will do today, keywords. So I start by a keyword to Selena. Red reflex reduced. When you see red reflex reduced in a scenario, what do you suspect?
Cataract.
Wrong.
Immature.
Yes, who said immature?
Immature.
Immature cataract. Good. Putri?
Yes, doctor.
Yes. Immature cataract, not just cataract, because cataract red reflex can be lost. Is there a difference between lost and reduced? Yes. What is the difference?
Lost is mature cataract.
Yes. What does it make as a difference? When you have a patient with cataract and red reflex lost, another patient cataract and red reflex reduced. What differs in the approach? Did you finish examination? Is there any step after the cataract, after the lens? Any structure yet to see?
If it's mature cataract, we can't see the retina, so we need to order B scan.
Yes. So see, this is how the question goes. When it is a mature cataract and you find the question is, what is the best investigation to get an idea about the fundus? It is B scan. In immature cataract, you can still see the fundus. It will need more effort, but you can still. At least you get an idea about optic nerve. Is it normal or not? Why? Because it is worthless to do the operation if the optic nerve is not functioning. The patient will not see. So if the patient is mature cataract and you do B scan, unfortunately, B scan does not show us the optic nerve. It shows us the optic nerve, but it does not show us how it looks. So how to get an idea about the optic nerve function if you cannot see the fundus?
RAPD?
Yes, the RAPD reflex. If it is positive, then this optic nerve is damaged. To what extent? Not your level. There is a grading for the RAPD, mild, moderate, and severe, but not your level. Just that you know that this optic nerve is not well. So we cannot promise the patient an outcome until we know what is the condition of this optic nerve. So the group discussion that you do with your friends, so is there any other disease that RAPD positive is significant. It tells us what is the disease. Anybody remembers? Patient sees nothing, doctor sees nothing.
Retrobulbar neuritis.
Yes, excellent. Retrobulbar neuritis. So now Selena learned from the first mistake of cataract that she didn't say just optic neuritis. She said retrobulbar. Why? Because there are 4 portions of the optic nerve that can be affected. But the most common is the retrobulbar neuritis, which is the intraorbital portion. We have intraocular, which is the optic disc that we see with fundus examination. We have intraorbital. We have intracanalicular. We have intracranial. The intracanalicular and the intracranial cannot be seen except with an MRI. And while discussing this together in the seminar of optic neuritis, there are many OBAs. One of them that Selena told us now, retrobulbar neuritis, is the most common. What is the most common disease, systemic disease in optic neuritis? It is multiple sclerosis. The most common portion to be affected, the retrobulbar or the intraorbital. Then a very important question: what is the first line of treatment? First line of treatment means we do other treatments, but we should start with this. What is it?
Systemic corticosteroid.
Intravenous steroids for 3 days. Then oral steroids for another 11 days. This is to reduce the frequency of the recurrence. And this treatment is systemic. So we will have a new jump now. What other diseases do we use systemic as the first line of treatment? So how to answer a question like this? Systemic means we need a fast-acting medication, and it is a condition that topical eye drops on the surface of the eye are not enough to manage. So we need something to go in the circulation and go to the tissues. So what are the structures of the eye that cannot be cured by just eye drops? The lacrimal cyst, dacryocystitis. Another jump to another topic: how to get lacrimal dacryocystitis. What is the most common risk factor? Stasis, obstruction of the nasolacrimal duct. Then what else that the eye drops cannot be efficient enough? Orbital cellulitis. Orbital cellulitis, a life-threatening condition. Why? We just explained the optic nerve. It goes up to the brain. So when there is orbital cellulitis, it can spread to the brain. So we need to hospitalize the patient and give him intravenous 3rd or 4th generation cephalosporins. How can the patient get pus? So where were us? Orbital cellulitis. How can pus reach this retrobulbar space? Definitely from a surrounding structure. What surrounds the eye? Sinus, nasal sinus. So when you are an ORL doctor and patient with acute sinusitis and his immunity is not that good, you should be worried about the extension to the orbital cellular, to the orbit to get orbital cellulitis, because nobody will die from sinusitis, but he can die from encephalitis or meningitis secondary to this orbital cellulitis. How do you suspect that a patient has orbital cellulitis and it is not preseptal cellulitis? Both from the front look the same. So we have to look from the side. Proptosis. And I hope you can get my point. When you have a patient with proptosis, the eye bulging outside the orbit, this means two things or three things. First, the eye is exposed. The lids cannot cover. So the patient can get exposure keratopathy. And exposure keratopathy occurs because this patient, during sleep, the eye rolls up and not covered by the lids, so it is in the lower 1/3. And lower 1/3 means away from the pupil, means will not affect the vision. But still, it is a risk factor for corneal ulcer. What is corneal ulcer, Selina?
Infection.
Yes, corneal ulcer is infection. And infection means we must know the organism. And this means we must take a sample. And we have 3 different samples in our course: conjunctival swab, corneal scraping, vitreous tapping. Once infection, then I need antibiotic. How to choose? We must know the organism. And until we know the organism, we give broad spectrum. Whether it is topical, systemic, intravitreal, it is the same concept that we must know the organism first. So we must not initiate the treatment until we take a sample. What to do with this sample? Wrong answer, culture and sensitivity. It is not for culture and sensitivity only. Before culture and sensitivity, it is for staining. When we stain, we know the type of the organism. Culture and sensitivity is to know the proper antimicrobial, whether it is antifungal, antibacterial. So how to know the antifungal if we don't know that it is a fungus first? So we need GIMSA stain and KOH stain. GIMSA stain will tell us it is a fungus. KOH preparation will tell us what type of fungus. Gram staining will tell us if it is bacilli or cocci, gram negative or gram positive. It doesn't tell us what is the antibiotic yet. It tells us what is the organism. While waiting, we start broad spectrum. If we start broad spectrum and after a couple of days you take a sample, this sample is not correct because the antibiotic has done some action against the organism. So what else occurs in proptosis other than the exposure? Diplopia. Why? Because the eyes are not at the same plane now. One is pushed forwards and maybe forwards and outwards, or forwards and downwards, or forwards and inwards. So the eyes are not looking at the same object. So the patient gets diplopia. What else? It is a volume in the orbit. After some time, there is no enough space, so it pushes the eye. After some time, it cannot push the eye forever, so it will press on the optic nerve. So we will get an RAPD positive. And this pressure, if not relieved, this can cause atrophy of the nerve. Same occurs in thyroid eye disease. The difference is this is pus, this is thyroid tissue. Same occurs in retrobulbar hematoma, but it is blood. Same occurs in optic nerve tumor or secondaries in the orbit, metastasis from a distant cancer. But they share the same concept, that the eye is pushed forward, it is exposed, there is double vision, optic nerve at risk. Since we talked about thyroid eye disease, what should we always remember about thyroid eye disease? Infection or inflammation?
Inflammation.
Inflammation. Inflammation means steroids. And steroids means high possibility of side effects, local and systemic. Side effects locally, risk for cataract, risk for open angle glaucoma, risk for corneal ulcer. Systemic, of course, you studied in medicine, hypertension and diabetes and weight gain and all these systemic side effects. What else do we treat using steroids? Some inflammatory condition very famous in our course, uveitis. And remember that uveitis and corneal ulcer, they share most of the symptoms and signs, except for staining of the cornea with fluorescent. In corneal ulcer, there is an opacity in the cornea. In uveitis, there is not. We are talking about a GP practice because ophthalmologists easily to differentiate by slit lamp. But for us, you have a torch. You can stain, corneal ulcer, antibiotic infection. Uveitis, corticosteroid inflammation. Can we use corticosteroids in corneal ulcer? Can. If there is yes, there is no, there is if. If there is inflammation. What is the inflammation in the cornea? Stromal infiltration. How to know satellite lesions in the stroma? So we use steroids, but we are not worried because we are already using antibiotic or antifungal. We are using steroids just for a short period until the inflammation subsides. We will gradually withdraw the steroids. But in uveitis, we have to keep using steroids until the condition resolves. Nowadays, there are more newer medications. Of course, they are non-steroidals, but are not as effective. Now, the cytotoxic agents and immunocompressant agents. So, as you see, it is all linked together. We talk about steroids, there is a risk of cataract. There is a risk of open angle glaucoma. Can cataract cause glaucoma? Yes, no, when, or how?
Yes, doctor.
When? How? Cataract, opacity in the lens, causing glaucoma. What do we call it? We have two names. Lens-induced glaucoma. Phacomorphic glaucoma. If you remember the name and you can translate phaco, lens, morphic, shape glaucoma. A glaucoma due to a change in the shape of the lens. What is the normal shape of the lens? Biconvex. In some conditions, the lens swells. What happens when it swells? It blocks the pupil. Aqueous cannot flow. Aqueous accumulates in the posterior chamber. Aqueous push the iris forwards, iris Bombay. The iris, when it is pushed forwards, it can close the angle. Angle closure glaucoma. So we must think, is anybody at risk for this? Definitely, those who are at risk are those who have a small angle, a narrow angle. Who has a narrow angle? Somebody who has shallow anterior chamber. And while discussing together this, how to know that the anterior chamber is shallow? Step number 3 in the local examination. You are standing at 45 degrees, but you shine the light at the limbus, very close to the limbus. If the angle is wide, the light will travel freely to the opposite angle, so it will cover the iris with light. If the angle is small, narrow, light will pass, then stop. So the iris will have an area covered by light and a dark area that we call iris shadow. So you can easily, if the patient tells you, is my cataract dangerous if I leave it? You check the anterior chamber. If it is shallow, he better removes it, because if the lens swells, it will block the pupil and will cause acute angle closure glaucoma. So instead of the patient free to wait for weeks or months, the angle closure glaucoma is an ocular emergency, because the optic nerve cannot stand this high intraocular pressure for a long time. And this brings us again to one of the conditions where the first line of treatment is systemic. Angle closure glaucoma, intravenous acetazolamide. Then we continue using the other medications, beta blocker, alpha agonist, carbonic anhydrase inhibitor. So our OBA is all the time what is the most common, the most diagnostic, the first line of treatment. So if you know that we have 6, 7, 10 topics, you can easily check which one has the type of question that it is first line. We mentioned today optic neuritis, first line is intravenous steroids. Angle closure glaucoma, first line is intravenous acetazolamide. Orbital cellulitis, intravenous broad spectrum antibiotics. Dacryocystitis, intravenous antibiotics. Endophthalmitis, intravitreal antibiotics. What if it is inflammatory endophthalmitis, not infective? So intravenous steroid, intravitreal steroids. How to go intravitreal? Pars plana. Where is the pars plana? 4 millimeters from the limbus. What else can we talk about? Retinal detachment, for example. What scenario do you expect for retinal detachment? 4F. Flashes, floaters, field loss, failure of vision. Flashes and floaters, retinal tear. Field loss, failure of vision, retinal detachment. Diagnostic investigation for retinal detachment. What do you order to confirm that this patient has a detachment? B scan. Do we have an A scan? Yes, A scan is axial length. This is biometry. But axial length alone is not enough. We need corneal curvature, keratometry. Both A scan and keratometry are called biometry. So in any case, going for operation, if we will insert the lens, phacoemulsification or extracapsular cataract extraction, we need biometry. B scan, check the back of the eye. It is a must if you cannot see. If you can see, it is okay. Current group in Ishtar, the B scan is not working for 2 weeks. So definitely the cases that went for surgery are the immature. You cannot risk taking the mature and discover later that they have vitreous hemorrhage or retinal detachment. In all conditions, whether you can see the retina or not, we do swinging light test to check the RAPD, because you have to make sure that the patient will benefit from the operation. Other operations that we studied, keratoplasty, changing the cornea. When the corneal ulcer first heals with an opacity blocking vision, second, not responding to medical treatment, third, cornea perforated, and less commonly, fourth, opacity that is cosmetically unacceptable by the patient and he doesn't see from another condition in the past history. So you have to know the names of these indications, which is very easy. If it is opacity blocking vision, so the indication is optical. If it is due to no response to medical treatment after a long time, and the more you use medication, the more the cornea gets sensitive to it, we call this therapeutic. If the cornea perforated, tectonic, to restore the integrity of the eye. And finally, the cosmetic. When we think about these indications, we have to grade them by the importance. So the tectonic is more important than the therapeutic is more than the optical. Why? Because sometimes we don't have enough corneas. So we have to know how to prioritize the patient, which patient needs it first. Then the types of the operation. If we change the whole thickness, it is called penetrating keratoplasty. If we change only part of the thickness, what do we call it?
Lamella.
Lamellar. So we have two types, 4 indications. Complications of any surgery in any curriculum, it will be postoperative infection. But in the eye, we call it endophthalmitis. And remember, what is the difference between endophthalmitis and panophthalmitis? Same presentation, but panophthalmitis has one more symptom: pain on eye movement, because the infection spread to all layers, meaningly the sclera is infected and the muscles are inserted in the sclera. What other condition has pain on eye movement? Retrobulbar neuritis. Pain mainly on looking upwards, because the origin of the superior rectus is very close to the optic nerve. So when the optic nerve is inflamed during the movement, this is the first muscle that touches the optic nerve. This is why we ask the patient before doing the extraocular motility. Tell us when you have pain, tell me. So you are moving, no pain, But when you go up, pain, immediately you suspect optic neuritis. If in all directions, you suspect panophthalmitis. What are the diseases that we can confirm using CT scan? Retinoblastoma. Why? Because retinoblastoma is characterized by calcification, and CT scan can show us associated pinealoblastoma, which is common with the retinoblastoma. What is the presentation of the retinoblastoma? White pupil, leukocoria. Is it the most common retinoblastoma? No. The most common is congenital cataract. But retinoblastoma is the most serious. It is malignancy. So if you ignore it, death. If you ignore a cataract, amblyopia. Yes, it is not nice amblyopia, but it is not death. How about retinopathy of prematurity? It doesn't occur except in premature. So in the history, definitely this is a premature baby who entered an incubator for some time and oxygen was full concentration. So the retina stopped to develop because the stimulus for development is the hypoxia. And this brings us into what does hypoxia mean in the eye. You remember on our Facebook group that you don't visit anymore? Once hypoxia, immediately release of vascular endothelial growth factors, formation of new vessels. And it never happened that new vessels didn't bleed. Why? Because they are abnormal weak vessels. They lack the normal endothelial wall. So they will bleed. Where do they bleed? In front of them. If they are in the retina, they will bleed in the vitreous. If they are on the iris, they bleed in the anterior chamber. What do we call new vessels on the iris? Rubiosis iris. And these new vessels on the iris, they cause a very famous condition called neovascular glaucoma in 90 to 100 days. Some people call it 90 days glaucoma or 100 days glaucoma in other books. How do they cause this glaucoma? Two mechanisms. If they form in the angle, because the iris shares in the angle. If they form in the angle, they mechanically block the angle. If they bleed, wherever they are on the iris, but they bleed, they cause hyphema, which can block the ankle. Where else can we have new vessels other than the retina and the iris?
Choroidal membrane.
Choroidal nuclear membrane. And when does this occur? Wet ARMD, which is not the common type. The common type is dry ARMD. And to remember dry, drusen. Dry, drusen. No treatment, just low vision aids, magnifiers, antioxidants, zinc supplements, and so on. But the neovascular membrane, let's go back to hypoxia, VEGF, new vessels, bleeding. How to stop? Stop the VEGF. Injection of anti-VEGF. Where? In the vitreous. How? Through pars plana. Better if you know the names for your own knowledge. Avastin was the one used before. Lucentis is the one used nowadays. Eylea is the most recent one. What if we don't have this injection? What is the alternative? Laser. But what type of laser? Pan-retinal photocoagulation. You don't need to know details of laser, but you have to know the concept. If the retina is hypoxic, we ablate all the retina. We just spare the macula. This is called pan-retinal photocoagulation, mainly done in neovascularization on the disc or neovascularization elsewhere. And both are called proliferative diabetic retinopathy. So what is the pathogenesis of this proliferative diabetic retinopathy? Blockage, occlusion. The common pathway of pathogenesis is leakage. Leakage of what? What is running in the capillaries? Blood. So leakage of blood and plasma. So we have hemorrhage and exudates, hard exudates. If this occur in the retinal periphery, we call it non-proliferative diabetic retinopathy. If it occurs in the center, in the macula, we call it diabetic maculopathy or diabetic macular edema. Completely different management. In both conditions, we must do FFA OCT. Then, if it's in the periphery, follow up every 3 months. If it is in the center, we have to manage either by laser or injection of anti-VEGF or steroids. Studies shows that both have the same efficiency, but steroids have side effects. So if you have the ability to inject anti-VEGF, it is better. No anti-VEGF can inject steroids or do laser. How to do laser? If the exudates are few, we shoot at the center of the exudates, focal. If it is filling the macula, you cannot shoot the macula, ablate the macula. So you do grid treatment. The only debate about non-proliferative is when it is severe non-proliferative. Some schools of medicine, they prefer to treat the severe because it is the last step before going to proliferative. When to say that this patient has severe non-proliferative, the 4-2-1 rule. 4 quadrants have hemorrhages and exudates, 2 quadrants have venous bleeding, or 1 quadrant having IRMA, intraretinal microvascular abnormalities, baby new vessels. And babies grow, so they will become new vessels. Once they are new vessels, it is not non-proliferative anymore. It is proliferative. So in diabetic retinopathy, you must know the pathogenesis, that there is long-standing diabetes, the most important risk factor, duration. What happens? Loss of pericytes in the capillary endothelial wall. What happens? Gaps in the wall. What happens? Bulging of these gaps, microaneurysm. Then rupture of microaneurysm, leakage. No ischemia. It is leakage. The other pathway, that this roughness in the wall of the endothelium, if the patient is predisposed with atherosclerosis, with hypertension, with blood coagulation problems, blockage occlusion. So there will be ischemia. The retina is suffering from hypoxia. It releases VEGF. What happens if we don't discover these new vessels and they bleed? We said they will bleed in the vitreous hemorrhage. If it does not absorb, fibrous tissue formation, contraction of the fibrous tissue, tractional retinal detachment, advanced eye disease. All this can happen in a patient with cataract, in a patient with corneal opacity, and you cannot see that it happened. So you need B scan to show you the vitreous and the retina. So it is a must that you know why do we do B scan? What is the value of doing B scan? What else we can talk about? Open angle glaucoma. If you have a scenario about open angle glaucoma, the disease, remember, vision thief, almost asymptomatic, maybe dull aching headache. But once the patient feels constriction of his field, it is late enough. So the only significant symptom is constricted field. This means what test we need to do? Visual field examination. And what we will find that the patient's field is smaller than our field. So he has constricted visual field. So remember in visual field, if you have watched the link, central field, peripheral field, 4 quadrants. ARMD,
Okay.
open angle glaucoma, retinal detachment.
426.
So you have to comment on the 3 parts of visual field after you do the test. There is no loss of central field, all there is central scutoma. There is no constriction of peripheral field, or there is constriction of peripheral field. And expect the question that you will be asked, of course. So what is your provisional diagnosis? Which eye? What type? So you cannot say glaucoma. You cannot say open angle glaucoma. You should say right eye, open angle glaucoma. Is it confirmed? The question itself is what is your provisional diagnosis? So we need to confirm. So what confirms perimetry? And the medications that we mentioned before, beta blocker, alpha agonist, carbonic anhydrase inhibitor, prostaglandin analog. How do they act? From the name, beta blocker, so decrease production. Alpha agonist, increase drainage. Carbonic anhydrase inhibitor, decreased production. Prostaglandin analog, both. If you know the names, it would be excellent. If you know timolol, alphagan, rozopt, and zalatan. So this is for the open angle. How do we confirm the angle closure? Is it from the vomiting and nausea? Is it from the conjunctival injection? Can be uveitis, can be corneal ulcer. It is from corneal edema, can be inflammation in the cornea. So how to know? How to suspect shallow anterior chamber? How to confirm gonioscopy? You will see that the angle is closed. Anterior chamber shallow, you are just suspecting. Angle closed, the angle is closed. Cataract, glaucoma, corneal ulcer, we didn't talk much about it, but we talked about corneal scraping. we talked about the first line of treatment, topical, broad spectrum, third or fourth generation cephalosporin, plus gentamicin. Then we give symptomatic treatment, atropine as a cycloplegic for the pain, beta blocker to reduce the intraocular pressure, and don't forget, if it is an SEQ, that we have non-medical treatment if the medical treatment fails, keratoplasty. In the open angle glaucoma, we have non-medical treatment, laser. In the open angle, argon laser trabeculoplasty. In the angle closure, iridotomy, peripheral iridotomy. Especially if the anterior chamber is shallow. In the other eye, we do as well. In the family members, we do as well. If the anterior chamber is shallow. This is why the examination of anterior chamber is shallow. No need for laser iridotomy because the risk for the angle to be closed is less. Then we have surgical trabeculectomy. It is the same for both types of glaucoma. So the difference in the treatment is one is systemic, first line, the other is topical. The laser, one is laser iridotomy, peripheral iridotomy. The open angle is trabeculoplasty. Confirmation, one is by perimetry, one is by gonioscopy. Completely different presentation, but they share the name glaucoma. This is why glaucoma alone is not enough as a diagnosis. For retinal detachment risk factors, I think I told you before, when we answer risk factors, we must grade them by importance. So please don't mention smoking in cataract as the first, but you have to mention it as the first in thyroid eye disease. You have to mention it early in ARMD, in central retinal vein occlusion. Myopia and hypermetropia, you have to remember which disease is at more risk. So myopia, open angle glaucoma, retinal detachment. Hypermetropia, angle closure glaucoma. So your exam is 11 and 13 October. Still you have like 3 weeks. I think if you check the Facebook group 5 minutes a day, this means 100 minutes. You will find lots of OBAs, lots of discussions about the main topics. If you just type glaucoma, cataract, corneal ulcer. So you don't actually need to hold the notes and read from them. Just answer questions and discuss with each other. That's what we did now in 1 hour. How many points did we discuss? Like 100 points. We don't stick to one topic. If there is relevance to another, we mention. When else can the cornea be exposed if there is no proptosis? So we said proptosis, the eye is bulging, whether it is cellulitis, hematoma, thyroid, tumor. But what if none of these, but the eye is exposed? When does this occur?
Facial nerve palsy.
Lack of thalamus.
Yes. Lag of thalamus is not a disease. It is one of the signs of facial nerve palsy, Bell's palsy. The patient cannot close his eyes, so the eye is exposed. So he gets exposure keratopathy and dryness. Dryness is one of the risk factors for corneal ulcer. So facial palsy does not result in corneal ulcer. It results in exposure keratopathy. And this exposure keratopathy can later develop into an ulcer if it gets infected. What is the common infective agent? It is Staphylococcus aureus. For the others, there must be an extra risk factor. For those who sleep with the contact lens or use the extended contact lenses, they get anaerobic infection, Pseudomonas. Those who shower with the lens or wash the lens with tap water, they get acanthamoeba. Nobody can get acanthamoeba unless they wash the lens with tap water or shower or swim with the lens. Nobody does not sleep with the contact lens or wear the extended wear contact lens can get Pseudomonas. Fungal, usually there is low immunity and trauma with a fungal matter, vegetative or infected branch of a tree is fungal. What else? Anybody has any suggestion? What else we can discuss? We discussed ARMD, dry, wet, drusen, membrane, no treatment or supportive treatment, and anti-VEGF injection. We discussed diabetic retinopathy, long duration, the pathogenesis, the investigations, FFA and OCT. You have to know what do they stand for: fundus, fluorescent, and geography. FFA, optical coherence tomography, OCT, vascular endothelial growth factor, VEGF, RAPD, relative afferent pupillary defects. And I said 100 times the name, relative, means to the other side. Afferent means optic nerve. What is the relative? A pupillary defect, pupil constriction. The pupil does not constrict as much as the other eye, and in the severe conditions, it even dilates against nature. It is supposed when we shine light that the pupil constrict. Here it dilates. So this is called RAPD. Since it is a simulated patient or mannequin, so you will not need to do the reverse RAPD, but usually when you discuss something at a higher level, your brain thinks better. So what is reverse RAPD? From the name is to diagnose or to suspect optic nerve function defect in one eye by checking the other eye, the reverse eye. Remember, you cannot see the pupil. You still shine the light by swinging light test, but you are focusing on one pupil. When light is on this pupil and it does not constrict as much as the other eye, then this is RAPD positive. When light is on the other eye and the pupil you are looking at does not constrict, it is reverse RAPD. And all this RAPD concept is because the only cranial nerve that crosses to the other side. 50% cross. So each side of the brain gets equal impulse from each eye. Which part of the optic nerve crosses? It is the nasal 50%. So when there is a disease affecting this nasal part, we get temporal hemianopy. When this problem is in the center, in the optic chiasm, we get bitemporal hemianopy. One of your friends here had this condition in the internal medicine, right, Selena? It was in internal medicine. So she saw the internist doing the visual field because the patient may have bitemporal hemianopia due to pituitary tumor, due to aneurysm in this area. What else? Corneal ulcer, cataract. Of course, again, since it is a mannequin or simulated patient, so you will not be able to find an artificial IOL. But when we have a patient with artificial IOL and we comment on the lens, we say pseudo fake. If there is no IOL, a fake. Please remember that during examination, fundus examination, our position is 15 degrees, same level with the patient, very close to the patient. Right eye, we use our right eye and right hand with glasses on or off, up to you, but the patient must remove his glasses. And if the patient removes his glasses, this means we must adjust the ophthalmoscope power. When we go to the left side, it is left eye using our left hand and left eye. Same steps, adjust the power, 15 degrees, same level. And before doing fundus examination, we have to do red reflex examination, because if there is no red reflex, you will see nothing. So red reflex, you are in front of the patient, same level with the patient, shine the light on the patient's face and compare the red reflex. In other examinations, including the pupil, we are at 45 degrees. And we keep instructing the patient to look far. Why? To avoid photophobia, to avoid accommodation. The first three structures, conjunctiva and the cornea and the anterior chamber, are in the room light. Then the pupil, lens, and fundus, we dim the light. When we inspect, we focus or don't forget to look at ptosis. How to know that there is ptosis? That the normal lid position covers 1 to 2 millimeters of the cornea. If it covers more, it is ptosis. If it covers the pupil, it is moderate ptosis. If it covers all the eye, it is complete or severe ptosis. And when you see ptosis, what nerve do you think of?
Oculomotor.
Oculomotor, third nerve, that has three functions. The lid that we just talked about, the extraocular motility, all muscles except superior oblique and lateral rectus, the one that you know, but many misinterpret, SO4 LR6, and pupil constriction. Because if there is pupil dilatation, not due to medication, pharmacological agent, we should suspect oculomotor nerve palsy, and the part that is involved in this pupil dilatation is at the origin in the brainstem, most probably an aneurysm, and this will need an MRI or MRA. If it is only ptosis or extraocular without dilatation, we don't need MRI. Remember that in chemical burns, we don't examine the patient. We manage once we see the patient by vigorous irrigation. Till when? Till when do we do this irrigation? Until the pH neutralizes. Which is more serious, alkali or acid? Alkali.
Alkaline.
Penetration. The acid causes saponification and protects the eye from penetration, but it's still dangerous because it causes opacity, adhesions, symblepharon later. What else? I think we covered all topics, cataract and corneal ulcer, if you remember. How to know the patient is improving in corneal ulcer?
Decrease in the staining in the ulcer size.
The ulcer what? Continue your answer. We said our answer should be complete. Clear,
Decrease
complete,
in the
and
size of
confident.
the ulcer in the
Yes.
fluorescein staining.
Yes, reduction of the size of the ulcer on staining. Today it is 4. Couple of days ago it was 6. A week ago it was 9. So it is reducing. This means our treatment is managing to control the infection. If it is increasing or not changed, this means the medication is not effective. It is an alarm that we might need therapeutic keratoplasty, or if it perforates, we might need tectonic keratoplasty. So this is the most diagnostic. Yes, the vision may improve, the redness improves, the pain improves, the discharge, the pus, the hypopyon, but all these are not the highest diagnostic. Because if all this is happening, but the ulcer is not reducing in size, what is the value of this? And some of them are subjective, sorry, like the pain. Some of them may not be present from the beginning, like the hypopyon. Not all cases of ulcer have hypopyon, but all of the ulcers have an opacity that stains with fluorescence. If this opacity keeps decreasing, reducing in size, this means we are on the right track. So in SEQs, when you come to the management question, please don't forget that management includes the investigations and the treatment, and treatment can comprise systemic, topical, intravitreal, laser, surgical. So don't forget the surgical while you already know the keratoplasty, but you didn't write it. Anything else anybody wants to ask about? Anything regarding the examination techniques? Don't forget in the visual field, if you are wearing glasses, you have to remove. If the patient is wearing glasses, he has to remove. You cover the opposite eye. You fulfill the whole quadrant. Don't stop when the patient tells you, yes, I can see. You begin by, do you see any defect in my face? Central defect, scotoma. You comment 3 comments, central field, peripheral field, 4 quadrants. In the ocular motility, you comment 5 comments. Remember? 2 from the patient, pain and diplopia. 2 that you inspect, limitation and nystagmus. And finally, conversions. When you finish, you go for conversions. And you have to be 50 centimeter because less than this, there will be accommodation from the patient, and accommodation includes conversions. So you cannot start while the eyes are already converged. You must start in the 0 position. And remember, the girls here, when you go out, don't go back. You go out, you are in the middle line. Don't go back. And when the patient is looking down, elevate the lids to see the eye. So introduce yourself to the patient, sanitize your hand, gain consent to examine, brief the patient what do you want him to do. In ocular motility, please don't move your head. In visual field, please don't move your head. Please don't move your eye. Look into my eye. So throughout the examination, you should be looking in the patient's eye and the patient looking into your eyes. This is the confrontation. We are comparing patient to us. In visual acuity, if the station is visual acuity, you must ask the patient to cover one eye. This is a must. Unacceptable if you don't. Your card in front of the patient's eye, 1 meter away. And then if the patient cannot see, while you are at 1 meter, you show him 1, 2, and 5, counting fingers. If the patient cannot see, so all these are ifs. We don't do counting finger if the patient can already visualize any line. Some of you did it during the videos, if you remember. So patient cannot be 6/18 and counting fingers. Definitely anybody who sees 6/18 can count the fingers. We do counting fingers if the patient cannot read any line. We do hand movement if the patient cannot count fingers. But hand movement is at 50 centimeters, not at 1 meter. We do perception of light if the patient does not appreciate hand movement. And the last one, if the patient does not appreciate perception of light, there is no extra test. It is just no perception of light. And remember that no perception of light is most probably a case of optic nerve atrophy. So the pupil should be dilated, irreactive. If the pupil constricts, this means optic nerve is still functioning. If it constricts as much as the other side, then the optic nerve is normal. So constriction of the pupil is not a sign that the optic nerve is normal. It is a sign that it is functioning. Equal to the other side, then both are normal. And the other test for optic nerve function are the visual field, the color saturation, especially red, and the light sensitivity or light saturation. But the most important to do is RAPD. Please, there is nothing called indirect pupil reflex. We have direct, we have consensual, and we have RAPD. And the third one is not swinging light. It is RAPD. Swinging light is a test, not a reflex. So you say, I want to perform swinging light test to check RAPD, not to check swinging light or not perform RAPD. This is a reflex, this is a test. Please remember that anything that you do by your own is examination. Anything that you request is investigation. So fundus is not an investigation. It is examination. It is included in our eye examination. Fluorescent angiography is an investigation. A-scan, B-scan, OCT, all these are investigations. CT scan is an investigation. So don't confuse what you do. Tonometry. Tonometry, you saw the doctors doing it in the hospital. They are not requesting it. So it is examination. On examination, intraocular pressure was 24. Does this mean glaucoma? 24? No. It is just increased intraocular pressure. To diagnose glaucoma, we must have visual field defect. All the others are suspicious glaucoma. Intraocular pressure, cup disc ratio more than 0.3. All these are suspicious glaucoma. Confirmed glaucoma, visual field defect by perimetry. So if the pressure is 24, 25, and the visual field is normal, this is called ocular hypertension. If there is visual field defect, cup disc ratio more than 0.3, but the pressure is 16, this is called normal tension glaucoma. See, we mentioned glaucoma, although the intraocular pressure is low or normal. Why? Because there is visual field defect, which means optic nerve dysfunction. Why? Because one of the functions of the optic nerve is the visual field. So we diagnose him as glaucoma, even though the pressure is normal. The other one we didn't diagnose as glaucoma, although the intraocular pressure is high. So ocular hypertension, normal tension glaucoma, open angle glaucoma. When all are positive, we call it open angle glaucoma. Angle closure glaucoma is a different scenario. This is a sudden increase because of the acute closure of the angle, ocular emergency. You may have seen it during the emergency on call, maybe. Okay. Please check the Facebook group. You will thank me later for this. There are many questions, about 70 or 80 questions. So they are covering most of the topics. Anything else? On the OSCE day, it will be 2 streams. So half of you will be in first stream, on the second stream. The most important is don't let any station affect the following station. Once you finish a station, close the book. Don't keep thinking, did I perform well? There is no time. It's only half a minute between the stations. So if you keep thinking of the previous station, it may affect the following 1, 2, or 3 stations. So don't expect a certain case just when you read the scenario. In 1 minute, 1.5 minutes, decide what you are going to do. Go with confidence. Don't expect facial expression or feedback from the examiner. The examiner is not supposed to be in the room. So don't, if the examiner does not tell you yes, yes, don't think that you are answering wrongly. He should not be giving you a feedback. So, and remember, don't answer in the form of question. So what is your provisional diagnosis? Don't say, is it cataract? Is it mature? You just answer, right eye mature cataract, with confidence. Because when you are confident, smooth, you are getting a higher mark than the checklist that you checked. This is called global assessment or global evaluation. So even for somebody who is not that good, if you are confident and smooth, but you made a mistake or you didn't collect the pass mark, this pass that you get can get you the pass mark. And after all this is an assessment of your skills. Don't take it as a life or death matters. And don't forget what you studied after you finish the exam. Definitely, I am sure if in the housemanship you show them proper attitude, confidence, they can depend on you. They don't need a burden, they need support, they need help. So don't go zero knowledge, zero skill and expect that they will teach you. You are supposed to go for the housemanship, start practice, at least good clerking, good attitude, knowledge. Okay, my friends. See you on the Pro 3. And inshallah in the convocation.
I have one last
Enjoy the
question.
study.
Doctor, for the ocular motility test, when after we do the H test, we want to do convergence, right? So do we ask the patient to look far first and then look at our finger, right? Or just
No, you don't ask
proceed?
the patient during the test. You ask the patient before the test. Please follow my finger, but don't move your head.
Then
If the
doctor, after
patient
the H
moves,
test.
after the H test, you go for convergence. He is following your finger.
Okay.
Please follow my finger means he will look out, up, down, then on the other side. Then when you approach, you try to look at your finger. So his eyes are supposed to converge and maintain the convergence. If there is weak convergence, or if he converges but does not sustain this convergence, this means he has problem with the medial recti or the oculomotor nerve.
Mm.
But all this before the test. Follow my finger. Please let me know when there is double vision. Please let me know when there is pain. Remember, the terms that you use with the patient are not that you use with the examiner. So don't tell the patient, tell me if there is diplopia. And you don't tell the examiner there is double vision. For the patient, please tell me when there is double vision. For examiner, there is diplopia on looking to the left, diplopia on looking upwards. We speak two languages, one with the patient, one with the colleagues. Okay. Any other question regarding the visual field? Please remember the 4 quadrants. You must cover the 4 quadrants. Please remember to change your hand when you are doing. You change and you use the other hand. We don't go to the opposite side. Please don't confuse the visual field with the ocular motility. In the ocular motility, the patient does not cover his eye. In both, the patient has to remove his glasses. Remember, in the visual acuity, when we comment aided and unaided, and aided, is it with glasses or with pinhole? If no pinhole available, you should request to do the test again with pinhole to exclude error of refraction. Remember, in fundoscopy, it is not written haphazardly that the patient is -4 in one eye and -6 in the other eye. Why should we mention this for you? So that we see you adjust the dial on 6 and 4 in red for myopia, in green for hypermetropia. And despite all this, it is a bad surprise in exam that some cannot assemble the ophthalmoscope or turn it on. Don't bring your ophthalmoscope. It will be provided if the station is fundoscopy, because all have to use the same ophthalmoscope. And you may use it as well in the ORL, otoscope. In other exams, you may find it in the internal medicine station. And you may find pupil station in neurology. You will find extraocular motility in neurology. Remember, why do we check the ocular motility? Cranial nerves 3, 4, and 6. So the pupil and the field and the contrast, cranial nerve 2. The motility and the pupil and the ptosis, cranial nerve 3. The motility 4 and 6 as well. Close your eye, blow your mouth, cranial nerve 7. Corneal sensation, cranial nerve 5. Part of cranial nerve 5, ophthalmic division of trigemini. So it is not just in ophthalmology. Nystagmus, that you inspect your ocular motility in many cases of ataxia in neurology, some cases of ORL. If I still remember well, if you inject hot water and cold water, different types of nystagmus. So these skills are not for exam, please, for the last time. If you lose these skills of the exam, then the exam is worthless. So you have to practice for your own, not for the exam. In the exam, you show us your skills. Take it this way, you are showing your skills, not pass and fail. Year 5 should not talk about pass and fail. They should talk about, am I good or very good or excellent? Okay. Thank you and very good luck. Don't
Thank
worry,
you so much, Doctor.
you should welcome. Anything else? Okay. Good luck and see you soon, inshallah.
Thank you, Doctor. Bye-bye.
Doctor.
Thank you, Doctor.
Painful.